Members, it's the appointed time and we have a quorum. I call to order the meeting of the panel on health services. First, I will invite the government officials to join us. Joining at this item, we have Secretary for Health, Professor Lo Chung Mo, Permanent Secretary for Health, Mr. Thomas Chen, Undersecretary for Health, Dr. Cecilia Fan, Commissioner for Primary Healthcare, Dr. Pang Fei Chao, Commissioner for Chinese Medicine Development, Dr. Vincent Chung, Director of Health, Dr. Ronald Lam. Also with us, we have the Chief Executive of the Hospital Authority, Dr. Libby Lee.
歡迎局長同埋團隊。
Welcome, Secretary and your team. Later, I will first invite Secretary to give us a briefing on his policies, then I will invite members to speak. Members who would like to speak, please press the request to speak button now. I will give each member 4 minutes, including questions and answers. Now I'll give the floor to Professor Lo Chung Mo, Secretary for Health, to walk us through the government paper first. Chair, members, I'm happy to be here to greet the newly elected LegCo members at this panel on health services. I'd like to take this special opportunity today to brief the new members of this panel on the policy initiatives of the Health Bureau, including our reform of the healthcare system as well as our work on developing Hong Kong into an international health and medical innovation hub. Hong Kong has all along have a high-quality healthcare professional system, and all the indicators are performing very well. For example, we're one of the regions with the longest life expectancies. Also, we have the lowest infant mortality rates in the world. On the other hand, we have a highly efficient healthcare system. Our recurrent healthcare expenditure on public healthcare only account for 4.3% of our GDP. This is lower than that of other regions and economies with similar proportion of aged population. With our healthcare system, we're able to provide 90% of the city's inpatient and inpatient services, and we have achieved a high international level in healthcare quality. However, we cannot be complacent. In the face of the aging population problems, we see an increasing prevalence of chronic diseases. This poses a burden on our healthcare resources as well as healthcare manpower, so we must persistently reform our healthcare system to cope with the challenges as well as to provide better protection for the health of our citizens. The current term government attaches a lot of importance to citizens' health. We actively take forward reform on our healthcare system. Since 2022, in the then Chief Executive's policy address, the government has already proposed reform of our healthcare system. The past policy addresses have announced a number of policies which include reform on public healthcare system as well as healthcare financing solutions. For example, we strive to develop our primary healthcare services as well as to ensure the sustainable development of our healthcare system. We also strive to develop Hong Kong into an international health and medical innovation hub. We want citizens to enjoy more advanced healthcare services, and meanwhile, we want to develop our biotechnology sectors. Now, Dr. Pang Fei Chao, Commissioner for Primary Healthcare, Dr. Vincent Chung, Commissioner for Chinese Medicine Development, as well as Dr. Ronald Lam, Director of Health, and Dr. Libby Lee, Chief Executive of the Hospital Authority, will brief members on the 12 major policies of our healthcare system. First, on developing Hong Kong into an innovative medical hub with the high-quality healthcare system in Hong Kong. We should be a leader instead of a follower, so we must develop ourselves into an innovation hub, making use of technology. This will allow us to provide the most advanced treatment solutions to patients. We can also at the same time promote new productive quality forces in terms of developing our biotechnology services. So then we can be a leading medical hub in our country. We have been speeding up the reform of our medical product approval system. For example, this year we will set up the regulatory center, and very soon we will table a bill to the LegCo in this regard. By setting up this Center for Medical Products Regulation, we will enhance regulation over medical products so that we can be an internationally recognized authority in Hong Kong. Through the approval mechanism, that is, apart from the existing 1+ mechanism, we will implement primary evaluation for new drug registration. Our target is to fully launch this system by 2030. As for the existing 1+ mechanism, it took effect starting from November 2023. So far, 16 drugs have been approved, and one of them are advanced medical products. Of the 16 new drugs, 7 of them have already been included in the HA drug formulary to provide more effective treatment for patients. The HA has set up an office to introduce new drugs to more proactively reach out to pharmaceutical companies. We will make better use of the 1+ mechanism. If there are new drugs or medical devices, we will encourage them to use the 1+ mechanism so that patients can get more cost-effective treatment options. At the same time, we will speed up the legislative exercise in relation to drug regulation. In face of the regulatory trends in the international community, we will amend our legislations and we will introduce the legislative amendments to the LegCo within this year. Apart from approval of newly registered drugs, we have to improve our clinical capacity in order to be an innovation hub. In the cooperation zone in the loop, according to the national standards, where we set up the GBA International Clinical Trial Institute together with the GBA Clinical Trial Center in Shenzhen. We managed to create synergies. We adopt the one institute, one center model, and this was set up last year. We will incorporate clinical trials for oncology research in order to benefit patients. We will also transform research outcomes into advanced treatment options for patients to promote new productive forces. At the same time, we have recently set up the real-life research platform. We make use of big data from the GBA and we tie in with the data platform built by the country to encourage pharmaceutical companies to leverage our strengths in Hong Kong to introduce new drugs used in Hong Kong to be used in the mainland as well as other parts in the world. In the long run, we need manpower in order to achieve the above goals. So we're actively building a clinical trial institute or academy, and our goal is to establish this academy by 2027 to support our work. Next, I'd like to move on to regulation over healthcare professionals. Healthcare professionals are crucial to the delivery of healthcare services. Apart from stepping up local training, we have introduced new policies to attract talents. In terms of local training, the CE in Council on the 18th of November last year approved the HKUST to establish the third medical school, and this is very crucial. It is an important milestone. The Hong Kong UST will admit 50 students in the 2028-29 academic year by offering a new 4-year graduate entry medical training program. This will not only fill the manpower gap, but at the same time, it is in line with our vision to develop Hong Kong into an international healthcare innovation hub. The government is finalizing the Memorandum of Understanding on implementation details with the Hong Kong UST. In the meantime, the task group on new medical school will support and closely monitor the work in the implementation stage. This covers the number of teachers as well as the relevant arrangements at the new medical school. In the meantime, we're also allocating resources to UGC-funded universities. In terms of UGC-funded healthcare-related undergraduate training places, the number has increased from 1,300 per annum in the year 2009 and 2010 to nearly 2,100 in the 2025-26 academic year, representing an increase of 60%. Under the study subsidy scheme for designated professions and sectors, the number grew even more rapidly. The number of subsidized places increased fivefold from 420 in the 2015-16 academic year to 2,100 in the 2025-26 academic year. The next topic I'd like to touch on is the e-health system. E-health was rolled out in 2016, serving as an electronic health system so that public and private healthcare providers can share among them electronic health records. As at last year, 6.8 million people have already registered with e-health. All public hospitals as well as private hospitals as well as over 4,400 hospitals have registered with e-health. So we see a very high utilization rate of the e-health system. And for the e-health plus, we have a high number of download rates, and as at last year, the usage rate exceeds 1.3 million per month. As announced in the policy address, we will develop a 5-year development plan for e-health plus. We've also got the funding approval. This will not be just a platform for sharing e-health records, but it will also be an infrastructure that cover health management and surveillance, as well as care coordination. We will take forward the development plan in accordance with the 4 strategic directions, namely One Health Record, One Care Journey, One Digital Front Door to Empowering Tool, and One Health Data Repository. We will adopt a multi-pronged approach to encourage private healthcare providers to more proactively deposit citizens' e-health records to e-health. This will facilitate citizens in managing and checking their own health records more effectively. On the other hand, we are gradually building a one-stop strategic health service operation platform to support and standardize the workflow and documentation of all subsidized healthcare programs. This will benefit the development of our primary healthcare system. Also, we are proactively strengthening e-health's integration and seamless connection with HA Go and other public and private electronic platforms. This will enable citizens to enjoy one-stop services and use this centralized platform to manage their healthcare needs.
官員彭飛洲
I'd like to call upon Dr. Pang to take us through the primary health care. In December 2022, the government rolled out the primary health care blueprint, shifting the focus from curative treatment to prevention. We'd like to build a sustainable healthcare system. According to the blueprint, in July 2024, the PHCC was set up, and measures are formulated to strengthen the primary health care. And we will be aligning with international standard and promote the training of manpower. To this end, the government has to draft legislation to empower the PHCC to lay the foundation for the formulation of the services, and also to build a cross-disciplinary network. We have the CDCC to encourage the members of the public to look after themselves and to pay attention to the health risks. And we are providing care to the patients. In 2025, we have increased the family medicine clinics to cover the entire Hong Kong, and we are providing services for the underprivileged. Other than the chronic diseases, we also cover the screening and treatment. We'll be enhancing the service capacity, and the service hours will be extended and regularized so that the members of the public would have their demands met. In November 2023, the government launched the CDCC. It is a co-payment scheme to encourage the members of the public to go to the private market to undergo screening and treatment in the private market. We have attracted 190,000 residents to join the scheme. 60% of the screening has been completed. The blood test and consultation have taken place, and 40% are diagnosed with diabetes, hypertension, and hyperlipidemia, and they have arranged to go to the private market for follow-up, and the government is subsidizing the cross-disciplinary follow-up to achieve the purpose of early identification and early treatment. And on the 7th, we have launched the Hepatitis B co-care plan, and this also covers the screening of liver cancer in order to minimize the risks. In the second half of the year, we will be launching the community drug formulary and drug community pharmacy scheme so that the members of the public would be able to get the drugs at an affordable price. And we're encouraging the public to use medication properly to minimize waste. And for patients who need prescription, they would be able to get the prescription before the next consultation. For those who are living in RCCs, there will be a medication distributed so that the staff members don't have to handle or sort out the medicine on a daily basis. We will formulate the drug formulary to cover more than 100 drugs, and this will be extended to cover 200 to 400 different types of drugs. In order to have a broad enough local network, in 2022, in 18 districts, the government has set up the DHCs or DH Express to achieve the target of covering the entire Hong Kong. As of December 2025, we're serving 3.7 million people, and the DHCs are beginning to set up the primary healthcare network. The government will be continuously expanding the network there. The women's health centers have been consolidated into the women wellness satellites, and we will be doing likewise for the elderly services. In terms of oral health, in 2025 March and May, we have launched the primary preventative oral health care for the adolescents, and the government will be, together with the private sector, provide preventative oral dental health care. Thank you. HA and Dr. Li Li, Chief Executive of the Hospital Authority. I'd like to bring you up to date about the enhancement of the healthcare of the Hospital Authority. We are the backbone of our healthcare system. We have a number of measures as follows. In 2024, we have enhanced the drug formulary and introduced new drugs, and we have shortened the time taken for the introduction of new drugs by half. We will set up the Office for Introducing Innovative Drugs and Medical Devices. This is intended to introduce innovative drugs and medical devices for the benefit of the patients. The QM has become the first chest pain center accredited by national standard, and the QMH and Tumen Hospital have become national accredited level 3 stroke centers. At the Prince of Wales Hospital and Hong Kong West cluster, we will set up chest pain centers, stroke centers, and integrated cardiovascular disease centers. We will continue to take forward the hospital accreditation program covering 7 clusters. And we will be helping the international hospital accreditation standards to go global. There are 7 hospitals that have passed or are in the process of getting the accreditation. We will take forward the system to the other 2 acute hospitals. We are going to be enhancing the workflow and improve patients' experience. We review the fees and charges and positioning to provide more choices to the patients. The HA has rolled out a number of measures to improve the waiting time for the specialty services. We'll continue to improve the booking arrangement and also improve the waiting time. In 2026-27, for surgery, stable new case bookings will be reduced by 10%. To enhance the ophthalmic services in all the clusters, we have introduced a high-capacity ambulatory cataract surgery center, and also the intravitreal injection therapy. And this ophthalmic nurses scheme will continue to be expanded, and the high-capacity cataract surgery center service will be expanded. For degenerative knee joint management program, this will be expanded to provide comprehensive set of service. We'll combine sports, weight management, physiotherapy, and integrated Chinese Western treatment in order to avoid a progression to a stage where surgery will be needed. We are introducing AI program to cover image analysis and other areas. We will be trialing digital pathology and the improvement of the workflow to enhance the quality. And we are harnessing AI to help the compilation of medical reports and the interpretation services for the patient consultation in order to improve the efficiency and patient's experience. As regards the reform on fees and charges, this has come into effect on the 1st of January. Since its introduction, we've seen some positive results. In the A&Es, the number of attendances have decreased by 10%, and all the emergency and critical patients will receive their services timely. And semi-urgent and non-urgent patients, the number has drastically come down by 20% compared with the same period last year. This goes to show that the reform will be able to help the poor, the acute, the serious, and the critical patients. And the efficiency can be enhanced there. We've also, alongside the reform, improved the fee waiver system. 600,000 people would be able to entitle to full remission. They include the OALA recipients, the CSSA recipients, and the care home voucher holders. And the number of people benefiting from this has increased from 30,000 people. We have already approved 100,000 cases of application, and this is far higher than the total yearly 14,000 in previous years. And this would enable us to focus our resources on the poor patients. We will deploy the dedicated team to handle the fee waiver application to shorten the time taken for processing. We will also set up the computer system to help with the tasks. For the critical patients, there will be $100,000 as part of the support scheme, and there will be more innovative medical products. We have also relaxed the criteria for application under the Samaritan Fund to include the middle-income patients. We will monitor the results of these reforms on a short, medium-term basis. On the basis of the existing system, we are reviewing the fees and charges every 2 years. Within 5 years, we should be able to achieve the 90% subsidization rate. As regards the cancer treatment and diagnosis, DHA is the largest service provider. We will be ramping up the cancer patient treatment. We will increase the genome checking services to provide precision medicine and to enhance the treatment results and treatment outcome and minimize the side effects. We will review the drug formulary and all the measures. Innovative anti-cancer drugs will be incorporated into the drug formulary. We are procuring the imaging equipment to boost the service capacity. And we are doing this in order to handle the demand for cancer patients. We are also bringing in qualified non-locally trained healthcare personnel, and end-of-life care will be stepped up. And for low-risk cancer survivors, they will be transferred to the primary care for follow-up. And we provide palliative care for the end-of-life patients in order to boost the services. We've also introduced life and death education as well.
主席跟
Thank you, Dr. Lee. Now I will invite Dr. Vincent Chong, Commissioner for Chinese Medicine Development, to brief members on our work to promote CM development. CM is an important part of our healthcare system, and people have been making use of CM services. The government has been rolling out different policies to ensure the high-quality development of Chinese medicine services. We have entered a new chapter in terms of our CM development. The government released last year the CM Development Blueprint. This blueprint is the first policy document published by the government specifically dedicated to the development of CM. This blueprint sets out short, medium, and long-term goals and action plans across key areas. It sets out our vision, and with the spirit of being innovative, the blueprint covers CM profession as well as CM inheritance and so on. There are 8 targets as well as 20 actions. We hope to leverage our advantages in the CM sector to make CM services more popular. We also help to strengthen our manpower for promoting CM to enhance people's health. Through this, we wish to enhance people's sense of well-being. The CM Hospital of Hong Kong and the permanent premises of the Government Chinese Medicines Testing Institute commenced services in December last year. It provides 3 kinds of clinical services. It marks the move of transitioning from Tier 2 to Tier 3 in terms of our CM services. It covers medicine, gynecology, as well as orthopedics and traumatology. It also provides oncological services as well as services for patients suffering from strokes. It also covers outpatient services provided by allied health professionals. There is a high demand for CM services, and we see a high booking rate. Since the commencement of the CM hospital, we have increased the number of booking quotas 3 times. There is advanced lab as well as international collaboration and training center as well as sample center. There are also 4 facilities regarding herbal medicine. We will continue to introduce high-end technology to increase the accuracy of CM testing to make sure that our labs and testing centers are in line with the international standards. We will also deepen collaboration with different institutions in the GBA and the mainland so that we can deepen collaboration with these organizations, and together we will promote the testing of CM as well as the use of CM samples and resources. We will continue to take forward the visions we set out in the development blueprint. We will make use of our wisdom to provide quality services to our citizens to enhance their health. At the same time, we want to become the bridgehead that establish for the global expansion of CM. Now I will invite Dr. Ronald Lam, Director of Health, to brief members on our policies. Director, please. I will now talk about disease prevention policies. Cancer sees a high mortality rate in Hong Kong. We adopt the early identification and early treatment approach, and over the years with our efforts, we see very effective cancer treatment. Over half of the population in Hong Kong has taken part in the risk-based screening of cancer, and we see a reduction in terms of our mortality rate for cancer in Hong Kong. To further reinforce our status to prevent cancer and to enhance our services provided for cancer patients, in January, the government has signed an agreement with the National Cancer Center. And this year, Hong Kong will for the first time host the World Cancer Congress. To provide screening services, we will make use of AI-aided lung cancer screening technology. And also for cervical cancer, we will enhance the relevant screening services and expand the pilot scheme on HPV testing of self-collected samples from the maternal and child health centers under the Department of Health to the Women Wellness satellites. Tobacco control is one effective way to reduce disease prevalence. Smoking could lead to various cardiovascular diseases, and the burning tobacco can release a lot of chemical substances that are carcinogenic. Our stance is very clear. We want to adopt effective measures to protect the health of our next generation. The government is currently in phases taking forward the tobacco control legislation amendment bill that has been passed. We adopt a multi-pronged approach on tobacco control to further reduce our smoking rates as well as to lower the harm of secondhand smoke on the public. The Customs and Excise Department is currently working on the duty stamp system, and the relevant pilot scheme has been successfully launched in January this year. It is believed that this will officially take effect on in Q2 next year. Also, there are 3 other measures that have taken effect. For example, we ban people from offering smoking products to those aged below 18. We have also expanded the no smoking area, that is 3 meters from the entrance of the designated premises. Also, the relevant fine has increased from $1,500 to $3,000 to increase deterrence. On the 30th of April this year, we will start banning the possession of alternative smoking products. Also this year, we will introduce subsidiary legislation in relation to the packaging of cigarette products. This is to tie in with the duty stamp system. Tobacco control requires all our effort. We strive to turn Hong Kong into a no-smoking city. Also, we strive to contain seasonal influenza. We've been monitoring the situation of flu in Hong Kong. We have introduced flu surveillance program into our sewage monitoring program. This can help us contain seasonal flu. Receiving vaccination can also reduce the chance of suffering from complications. The 2025 flu vaccination programs have commenced in September 2025. To encourage the public to get vaccinated, we have rolled out 5 enhancement measures that include expanding the eligible groups, enhancing school outreach, and the eligible groups will cover those aged between 18 and 49. We have also provided nose spray as the vaccines, and we are also providing flu vaccines to the elderly, and in residential care homes we have also piloted vaccine procurement for family doctors. To facilitate people in getting vaccination in different clinics, we are offering vaccination service for those aged between 6 months to 2 years old. They can get the service in the 29 maternal and child health centers. For those aged between 18 and 49, they can go to the district health centers as well as the district health center expresses across all 18 districts to get vaccinated. We appreciate the support from different sectors. As at the 18th of January this year, we have already given 1.96 million jabs, up 2% compared to the same period last year. We're doing quite well in schools as well. We see an increase of 2 to 2.8% of school children who are receiving jabs, and over 2,000 schools, that is about 98 to 99% of the participation rate in the vaccination program. the flu season is approaching, so I appeal to citizens to get vaccinated soon. Apart from physical health, mental health is equally important. In terms of our policies, we adopt a multi-pronged approach and we involve multidisciplinary participation. We provide early intervention and early identification services. The Shall We Talk program enhances people's awareness of mental health, and we encourage them to seek help as early as possible. This is also to dispel misunderstandings of people with mental health problems. To encourage people to seek help early, in December 2023, we rolled out a support hotline. The purpose is that we want to offer one-stop services by providing 24/7 hotline services. As at November 2025, we have rolled out 4 enhancement features that includes booking on WhatsApp as well as multilingual support. At workplaces, we also offer mental health support. The advisory committee as well as the health department rolled out the mental health charter. As at December 2025, about 3,000 organizations covering 180,000 employees have taken part in the charter. We also rolled out a theme this year that's about interpersonal relationship. We also rolled out a mental health award scheme to provide mental health support training for employees. There are 3 DHCs that provide mental health support. It offers free mental health assessment to citizens. In 2026, we will extend the service to 9 DHCs. For those with counseling background or psychology background, they will provide the services. Targeting young people, well, we concern the impact of social media and the use of electronic screens on the development of children. In the 2025 policy address, it is announced that we will amend the relevant guidelines. In October 2025, the Department of Health has already set up a multidisciplinary group, and it is expected that within this year we will release our recommendations on the use of electronic screens and social media. In December 2025, the Advisory Committee on Mental Health submitted the framework for the stepped care model to the government. We drew reference from this stepped care model. For example, for step 1, we enhanced 181112 service as well as the Shall We Talk support when we offer support to affected residents in the Tai Po fire. For example, for the 3rd tier, the Social Welfare Department works with the Health Bureau to provide specialist mental health services to the affected residents. To protect citizens, we have to move with the times in terms of reforming our manpower structure. In year 2025, we amended the Dentist Registration Ordinance, Nurses Registration Ordinance, and the Allied Health Professions Ordinance. These amendments expanded the pathways for admitting non-locally trained healthcare professionals and implemented measures such as mandatory continuing professional development. The existing continuing professional development system will be made regular and it will be enhanced. We are in talks with the relevant stakeholders. We believe the new system will be rolled out this year. We are also building an e-platform in this regard. As for the Medical Registration Ordinance, we will introduce an amendment bill to the Legislative Council this year to support the medical profession in maintaining professional standards. At the same time, we strive to enhance regulation over private healthcare facilities. On one hand, we want to increase the transparency of price information of private healthcare facilities. Last May, the government already briefed this panel on Section 61 to 63 of the Private Healthcare Facilities Ordinance. There are three parts to this. First, private healthcare facilities must make public their price information, and all the information must be published on their websites. Also, if patients ask for specific treatment services, the private hospitals concerned will have to provide budget estimates. Also, private hospitals will have to make public the history of the historical statistics on fees and charges.
Members and the stakeholders welcome these proposals. We hope that by the time we introduce these measures, we will tackle the issues. And also to guard against illegal practitioners using misleading titles and descriptions, we will be implementing Section 92 of the PHFO for the non-licensed private hospitals. The procedure centers, if they're not supposed to use the titles and descriptions. We are reviewing all these titles and description. In the first half of this year, we will be consulting the council. Thank you. The last measure, Mr. Chairman, is the cross-boundary healthcare cooperation. We seek to abide by the principle of complementarity and mutual benefits and enhance the quality of service. We aim to provide convenience and a broader range of choices for the patients. We have the EHR sharing, and we have the Elderly Healthcare Voucher GPA pilot scheme, and this is a starting point for us to introduce the personal folder and also the cross-boundary health record. We have enhanced the functionality there. The members of the public can transfer the high-resolution radiology images and reports compiled by the three hospitals in the GPA to the e-health system, so that there would be better connectivity in the service care. We have also introduced the direct cross-boundary ambulance transfer system. We cover Shenzhen and Macau, and in November we have included Nansha and Zhuhai in the pilot scheme. We will expand the scheme to achieve a two-way system. As to the cross-boundary use of the elderly healthcare voucher, we started in 2024. Initially, we had only the Hong Kong U Shenzhen Hospital, and we're expanding these to 21 service points. There are many firsts, and I don't propose to give you the details here. Simply put, 27,500 citizens have joined, covering 60,000 cases. This is very much a milestone there, and this is a very good policy to link up the two places and improve the bonding. And we have the pilot scheme for supporting patients of HA in GPA, and the patients will be given more choices. Chairman, we have highlighted the 12 different areas of policies. Now, this covers a very broad spectrum, but suffice it to say that since the beginning of the term, we have been trying to improve the healthcare services by reforming the system so that the services can be improved. Second, we'd like to go global. We're not trying to expand the services in Hong Kong. We're trying to develop an international health and medical innovation hub. In terms of medical services and medical devices, there will be a reform, and we do need to seek members' views and conduct consultation on these legislative proposals and all the rest of the measures. I look forward to the support and cooperation of members going forward. There are many initiatives that will be taken to members for consultation going forward, and we will have to go down the legislative path. In some cases, health is the biggest, the best wealth. The health and wealth rhyme in English, and health comes before wealth in terms of alphabetical order. So health is far more important than wealth. President Xi said that health is one of the most important indicators for well-being. And in the coming year, we look forward to cooperation with members of the council so that the members of the public would get what they deserve in terms of health care. All right, thank you very much. There are 12 members on the list. I read out the names: Mr. Adrian Ho, Mr. Chen Hock-Fong, Professor Chen Ming-Kwong, Mr. Oden Chow, Ms. Jovi Chen, Mr. Chen Pui-Leung, Mr. Peter Xiu, Ms. Chen Hoi-Yan, Ms. Grace Chen, Mr. Mark Chong, Mr. Yeo Ming, and Ms. Christine Fong. I draw a line there under the last speaker, and if members still wish to speak, please press the button, 4 minutes each. Mr. Adrian Ho, please. Chairman, thank you. Thanks very much, Secretary, and your team. I've got 2 questions for the Secretary. Other than regulating the medical or healthcare premises in Hong Kong, there are many mainland dental and medical beauty organizations in the mainland and overseas. Will you be regulating these as well to ensure there will be a level playing field? There are 946 non-locally trained healthcare personnel. Where did they come from, and what language do they speak primarily? And when introducing the non-locally trained healthcare personnel, would you consider giving priority to the language or the language proficiency in Cantonese? Secretary, yes, on the first question for the advertisement for healthcare services, we have the undesirable medical services ordinance, and we also have regulation on the healthcare personnel. I defer to Dr. Leung in this regard, please. Director, if they are in breach of the legislation regarding the undesirable medical advertisement, we will take action there. And on a daily basis, we do have a team dedicated to monitoring the advertisements in the media regarding healthcare. We follow up on those. Second, as we reported, in the first half of this year, we will be introducing the measures to bring into effect Section 92 of the Private Healthcare Facilities Ordinance. And there are some centers we claim to be pain relief centers, and we have to make sure that they are sufficiently qualified before they would be able to use the titles or descriptions. Second, we need to regulate the premises, and since December last year, for clinics and small-time clinics, we have accepted the application for a letter of exemption. We are receiving application right now, and I've got some numbers here. For clinic licenses, we have received 233 applications. Provisional license, 4 for small-time clinic exemption, 2,122 applications, 1,500 exemptions have been granted. Now, to make people aware of whether the clinics are exempted or whether they have a license, we will be mounting publicity, and we will remind the clinics that they have to display the QR code to let the patients identify them. Now, locally trained personnel, let me say this. They come from different jurisdictions. Mainly, there are different organizations, HA, DH. They mainly for the provision of services. We also have the doctors and dentists. The universities have also hired some of them to meet their needs. You mentioned the language proficiency. Depending on the organization and the service needs, that we will look at the language proficiency there. Thank you. Mr. Cheng Hock Foong. Chairman, thank you. The public health care in Hong Kong is something that we all rely on, that we put faith in, and it has been providing really brilliant services for Hong Kong. Now, we have seen an upward revision of the fees and charges, in particular the A&E. People do understand that, because people should not be abusing the A&E services, but the fee hikes are affecting the specialist care as well. Now, with the fee hikes, people will have to bear 4 times or 5 times more than they used to pay. There may be a ceiling, but there are some people, some middle-class people, who do enjoy the exemption. They have really an added burden. And the fee hike is intended to drive some of the people to the private sector, and that's understandable. But for the private sector, fees and charges, there is no control there. I've heard some private clinics or family doctors who are putting up their fees. And I mean, the government is putting up the fees and charges. The private sector is also doing likewise. Are there any ways the government is going to be monitoring the situation in the private sector in terms of fees and charges? And we talked about the healthcare voucher schemes, and the doctors would tend to ask them whether they have the vouchers. If they do, they would be charged more. Now, how are you going to be monitoring these kind of abusive fees and charges? I think it would not be good for them to go to the public sector or secretary. Now, this is a reform. There is increase, there is reduction. The overriding objective is to use the resources more properly to ensure sustainability, and also to protect those who are in genuine need of medical care, including the poor, the acute, the serious, and the critical. We managed to achieve this target on the basis of the reform. You mentioned some of the examples there a moment ago. We have to bear in mind that there should be a co-payment system for those who can afford. This is also part of the reform. You mentioned some patients have to pay more if they are suffering from financial hardship. There is a waiver system. Dr. Libby Lee has already said that we had 300,000 people making the application before. Now we have 1.4 million making the application. Per year, we had 14,000 people who are entitled to waiver. Now we are talking about 110,000 who are entitled to the waiver. In other words, 80,000 people who otherwise did not have or did have to pay, and now they don't have to pay anything at all. So I hope that you would appreciate that we have really provided the relief for the needy. If they see the need, that they can come to us for the waiver. There are some who may not be part of the 11 or 110,000. In fact, 1.4 people are eligible. They don't necessarily have to come forward. Now we have the second safety net. Now we don't have the numbers for you, and there's the ceiling of $10,000 for the 7.5 million people. There is no need for means test. Now this is really a safeguard. Very quickly, Chairman, you mentioned the fees and charges in the private sector. We don't have any figures to show that the private sector is putting up the fees and charges because of the fee reform in the government. If you do have the statistics, please let us have them. We monitor the situation, though.
Wing Kwong.
Thank you. Next Deputy Chair, Professor Chen Wing-kwong. The DAB is concerned about the medical fee reform. According to the latest statistics from the government, after the launch of the reform, those who go to the A&E Department of Public Hospitals drop by 15% compared to the same period last year. For urgent patients and non-urgent patients, the number of attendances also dropped to 21%. It seems that the government has achieved its goal by rolling out the reform. However, a lot of people from the grassroots said for critical patients and non-urgent patients, they all have to pay $400 if they visit the A&E department. Unless they face critical conditions, they would not choose to go to the public hospitals for consultation. Most of the members of the public are not working in the healthcare sector. They cannot judge by themselves whether they are in critical conditions or not. So what measures will the government put in place to prevent the situations where people get delays in their treatment by refraining from visiting public hospitals? Also, I want to know whether the reform of medical fees has achieved any effectiveness. Now, turning to clinics without licenses, the government said that it would regulate centers that claim to be pain relief centers. However, there are many misleading advertisements online. Apart from regulating their titles, what measures will the government put in place to prevent doctors without license from practicing? Secretary. Now, the $400 of A&E fees, it's about 20% of our costs. So I want us to be clear about this. We cannot compare the fees charged by the A&E with that charged by ordinary family doctors. Our healthcare professionals working at the A&E departments, they have received special training so they can deal with patients with urgent conditions. I think Professor Chen pointed out the importance for us to roll out the reform on medical fees and charges. We want to prevent people who are not in critical conditions or serious conditions to visit the A&E. As for patients who aren't sure about the seriousness of their conditions, well, I believe those who suffer from mild symptoms, they would know that they are not in serious conditions. It's just that the A&E fees were too low. Therefore, a lot of people opted to go to the A&E regardless of the severity of their health conditions. I want to tell people that they should not go to the A&E regardless of their conditions. If patients really aren't aware of their own situation, there is a triage system. When they visit the A&E department, the staff there would tell them which tier they belong to. Usually for Tier 1 and Tier 2 patients, our staff could identify immediately that their conditions are serious. So they could decide when they get to the A&E whether they want to pay the $400. And if they cannot afford the $400, our staff on site could help them apply for the medical waiver. If patients could not immediately provide documentary proof showing that they are eligible for the medical waiver, they could get a provisional medical waiver. They would get the relevant certificate to exempt them from paying the medical fee for the coming 3 months. This mechanism is in place to ensure that those with financial difficulties won't have to shoulder the costs. As for the question about clinics claiming to be pain relief centers, I will give a supplementary reply after this meeting. Next, Mr. Holden Chow. I have 2 questions. One of the questions was raised by Mr. Chang Hok Fung already. He asked about the medical fee and charges reform. I myself also said that we should exempt the medical fees for elderly people aged 75 or above. Can we lower the threshold so that those aged 65 or above and are getting the old age living allowance can be exempted as well? We have to take into consideration the needs of elderly people. For those who need healthcare services and with financial hardship, can we offer more support to them? Also, if we lower the threshold, how many people will be covered under the medical waiver mechanism? If there isn't a significant difference in terms of the number covered under this mechanism, we might as well offer more support to our seniors. Also, I see that when patients apply for the medical waiver, they have to go through some paperwork. They rely on the help of social workers at the hospital to complete the application. The paperwork is rather cumbersome. Is it possible to streamline the procedures? Is it possible for the SWD to step in to help patients complete the applications? My other question concerns the virus outbreak in India. That's known as Nipah. I understand that there will be guidelines to help guard against this virus. I want to know if the government will take further measures because this virus seems to be very serious. So we want to guard against this virus. Thank you. Secretary. This meeting is a policy briefing meeting. I understand that members are concerned about the virus, but in the interest of time, let's focus on our policies today. On medical fee reform, we adopt the co-payment model as well as the affordable users pay principle. We want to focus on helping the poor patients, the acute, the serious, and the critical patients. So Mr. Holden Chow proposed lowering the threshold to those aged 65 or above. This would minimize the positive impact brought by this medical fee reform. There are 24% of our total population who are aged 65 or above, and this percentage will increase to 36%. That is, over 1/3 of our population will be those aged 65 or above. So when we try to draw a line, we have to tread carefully. We took into consideration this factor, and we think that the current mechanism is appropriate. At the moment, I think it is appropriate for us to draw the line at the current level. As for the medical waiver application, this is an expanded medical waiver mechanism which are benefiting more people compared to the past. For those who have financial difficulties, it should not be too complicated for them to declare their income. And if they are already receiving benefits from the Social Welfare Department, we should have their information already. And for most of the cases, they don't actually have to go to the social workers to complete the applications. We have a lot of clerical staff on site to offer help to them. Next, Ms. Jovi Chen. Thank you, Chair. I'm glad that the government took on board the FTU's proposal to promote the use of registered drugs in Hong Kong to the mainland. I'm also happy to see that there is a new office to be set up to introduce new drugs in Hong Kong. I also support the 1+ mechanism. All these measures can ensure that patients can get the most advanced treatments. I understand that the State Council also set up a special healthcare zone to try out new drugs or new medical products. I have visited Boao, that is the special zone, a number of times. I hope that the elderly healthcare voucher scheme could be expanded to Hainan. We should also speed up the approval process for new drugs. I hope the government would consider this suggestion. Now turning to medical fee reform. Members of the public are highly concerned about this new measure. I know that medical waiver application will be digitalized by about the 30th of June this year. There's still some time before June, so can we speed up the digitalization process? Also, we have a suggestion for those aged 65 or above who are receiving the elderly living old age allowance. Can they get the medical waiver as well? Can they be exempted from the administrative procedure if they want to apply for the medical waiver? Also, I noticed that 82% of the patients could get the medical waiver on the same day. So how many patients are getting conditional approval on the same day? They have the documentary proof with them, but the proof was not examined by the staff on site, and they were asked to apply again 3 months later, and in the meantime they will only get the provisional medical waiver. We see that 82% of the people are getting the medical waiver. It's a good figure, but then overall speaking, the application procedure is too cumbersome for patients. Also, the Secretary said just now that there are no statistics showing the impact of the public healthcare fee reforms on the private sector. Can there be a comprehensive review in this regard this year? Secretary, on whether healthcare vouchers could be used in Hainan, I think we have to consider how many elderly people from Hong Kong are currently residing in Hainan. As we expand the healthcare voucher scheme, we have to take into consideration how many people will benefit. There are so many provinces in the mainland, so how many provinces should we cover? Also, the member just now mentioned that there's a special tariff zone in the mainland, and this has not much to do with our healthcare voucher scheme or new drugs introduction. It's just that for new drugs that are approved in the mainland, they could be used first in that particular place. As for the medical fee reform that all members are very concerned about, I always ask you to pay attention to the statistics. I want to reiterate that over 111,000 people have already got the approval under the medical waiver mechanism, and the applicants have dropped from 5,900 to 4,800 per day. So we have already passed the peak. And among the 110,000 people that have got the approval, 13,000 of them have already got the waiver certificate, and this is valid for 18 months. And during these 18 months, if it is proven that their economic status has not changed, they could apply to renew the certificate. As for the remaining 60,000 patients, they did not provide proof on their asset as well as income level on the site, and so they got a provisional waiver, and that is valid for 3 months. We're talking about very important healthcare resources. We have to make sure that these 60,000 patients who claim to be eligible for the medical fee waiver mechanism, they have the responsibility to provide the relevant documentary proof. At the same time, we will do sampling checks to make sure that no one is abusing public healthcare resources. As for whether people need to apply again, well, they don't need to. It's just that some patients, they failed to provide documentary proof when they visited the hospital, so we issued a provisional certificate to them. Some patients, they have to attend follow-up consultations in public hospitals, so every time they visit the hospital, they could submit the documentary proof. So it's not that they have to reapply, it's just that they have to submit the missing documents.
多同事都關
Well, in the interest of time, members are very concerned about the fees and charges. Maybe we can have a special item for these future meetings. Mr. Chen Pui-leung, in the paper there is a mention of the setting up of an office for introducing innovative drugs and medical devices in the HA. And this year, the government will be setting up the CMPR, the Center for Medical Products Regulation. Now, one entity is to introduce these devices. The other one is for supervision and regulation. Why do we have to have two separate entities dealing with the innovative drugs and medical devices? Now, we're dealing with this category. Is there any way we can somehow house them under one umbrella to fulfill the function much better and also to utilize the resources that much more efficiently? Second, about personnel training, the HKUST will be setting up the third medical school, and there's going to be a graduate level graduate entry medical training. Admission will take place in 28-29. You are recruiting the graduate students. For the other two medical schools, they are also admitting the graduate entry candidates. So these three medical schools, would there be a mechanism whereby the three medical schools will be engaging in vicious competition for the admission of students? Thank you. Secretary, thanks very much, Mr. Chen. You mentioned the function of the CMPR under the DH and also the Office for Drugs and Medical Devices under the HA. They are serving two different functions. They should not come under one single organization because there is potential conflict of interest. That the DH drug office, it is there to make sure that the innovative drugs and medical devices are good enough in terms of quality and efficacy. It's only when the drugs have fulfilled these criteria before they would be approved, and they are serving the role as a regulator. But for the HA, they have regard to the needs, the clinical needs of the patients before deciding on a certain drug and medical device, that they are approaching this from the perspective of a user, regulator, and user, they are serving two different roles. They need to communicate, but they cannot be merged into one single entity. That's why we have to have this office. Now, for the regulator, if the drugs and medical devices consider them to be good enough, the patients may not be deciding to use them because they have to consider the cost effectiveness, the prices, and the alternative choices, and so on. So the roles are different, but they need to talk to one another. In particular, when HA is using certain drugs, right now under the 1+ mechanism, if there are certain clinical needs for certain new drugs on an urgent basis, if there are certain new drugs that are coming on stream that would be of help, and they would try to seek the approval of these kind of drugs. You mentioned the third medical school. It is admitting graduate entry or graduate candidates. The other medical schools do admit similar students. And this third medical school would broaden the source of candidates. We do not see any vicious competition there. Primarily for the third medical school, they will be adopting this model. For the other medical schools, they would be using the conventional way of admitting students from the secondary schools, and so on. Mr. Peter Shiu, Chairman, the paper is really comprehensive. Reform for the Chinese and Western medicine and all the other reforms. I'm all in support of these. I'm grateful for their hard work. There are 2 points I'd like to make. Para 12 in 2026. There will be the CMPR, Center for Medical Products Regulation. A bill will be introduced to the Council soon. There are some people from the beauty sector who are concerned about the regulation of the medical devices and that beauty, the devices may be covered. If they are using the high-energy devices, we agree that they should be coming under the regulation because this is likely to give rise to harm caused to the users. But many of the devices they are using are not really of high-energy type. And I hope that the Secretary or the Undersecretary will be setting up a meeting for the beauty industry for them to articulate their views, for you to understand their position. Second, Para 32, tobacco control. In 2023-24, the government has put up the duty for tobacco twice, and this is intended to minimize smoking or reduce the smoking rate. The overall direction is to reduce the smoking rate, and we're all in support of that. But after the 2 hikes, statistics show that in 2023-24, it was 7.2 billion or 3.1%, and you had another 3.1%, assuming that in 2023, the 9.1% smoking population, if the population remains, then the revenue would be 1.22 billion. But the figure is now standing at 420,000, a shortfall of about 60%. Now, since there is a reduction of 1% of the smoking population and there is a shortfall in the tobacco duty, now this is really something good. But what is the latest smoking population? I think it's, the number is due for release. If the smoking population is not really down that much, and if the tobacco duty increase doesn't really achieve the purpose, what other measures do you have up your sleeve? Secretary, medical devices, we don't have any legislation governing this. That's why we have to go down the legislative route to regulate this in order to ensure the safety of the patients. Now we're regulating the medical devices because they are terribly important for the patients. We would consider how best regulations should take place, having regard to the international standard. You mentioned that we haven't yet come up with any models, and I don't think it would cause a lot of concerns unless you are using medical devices in such a way that would cause danger. When we have the details available, we can have more discussion. The smoking rate 2025, we are still conducting the analysis. Examples worldwide show that tobacco duty is really instrumental to the reduction of the scourge of smoking, and this is one of the most important tools. With the hike in tobacco duty, we have to assess the effectiveness having regard to the 2025 smoking rate. Now, the tobacco duty, there are many factors at play, like the cross-boundary flow of people, and people are using tobacco outside Hong Kong, and that's one of the factors that should be taken into account. We have the duty stamp as a means to tie in with the tobacco control measures. Mr. Peter Shield. About tobacco duty, Chairman, with the smoking prevalence available, we can certainly have more review. Secretary, I hope you would talk to the beauty industry because they're using medical devices anyway. You might wish to have some exchanges and consult their views. Yes, indeed, we will send about the consultation at the right time. Ms. Yan Chen, I'd like to extend the meeting by 15 minutes. Ms. Chen. Chairman, I'm also concerned about the fees and charges reform in the public sector. It is really difficult for successive terms of administration. Now, this has been in place for 30 days, and it would be hard for us to come to any conclusion about the effectiveness of the fees and charges revision. I hope that the administration would let us know about the people. Well, otherwise we go to the A&E that do not go to A&E now. What is happening to them? Are they self-medicating, or are you successful in shifting them to the private sector? What we are concerned about is people don't really seek any medical attention and cause problems to themselves. Second, according to the paper and also from the presentation, the government is saying that progressively the fees and charges will be subject to review every 2 years. How do you decide on the 2 years? And within 5 years, you should be able to achieve the subsidization rate to 90%. Now, where do you derive this number from? How did you come to this conclusion? Next time, when we conduct the reform, at this time, we were only informed of the details. Members have not got any opportunity to give our input regarding the fees and charges. If you look at the fees and charges, the mortuary fees also come under this package. This has caused a furore when the proposal was first put forward. Members are airing the views of the public, and I hope that in future, for issues that are related to the day-to-day life of the members of the public, if you revise the fees and charges, I hope that you would have listened to members' views, so that collectively we will be able to come to any consensus. Otherwise, the situation may become undesirable. Second, the second hospital development program. The paper is silent on this. I understand because of the changes in population, some of the redevelopment program will have to take place in 2026. Are there any development plans that have been scrapped? Secretary, for the fourth and fifth type patients, the A&E patients have decreased. When we consider the revision, that's one of the important area, and that's the pain point. There are so many patients with mild illnesses that are flocking to the A&E. The numbers show that people in this category have decreased in numbers, and they are classified as types 4 and 5, and there are so many ways that they can deal with the ailments. We should not be too concerned about these issues. And if they turn up at the A&E, they will have to wait for a pretty long time, and they won't have their own way to deal with that. Like headaches, they can be paracetamol that can be used. Cold, common cold, that they can also be dealt with. That you express concerns that some patients may not get medical attention. We should be looking at the type 1 and type 2 patients. If we've seen a reduction there will be problems. But for these two types, they enjoy free consultation. And the numbers are showing that we're not seeing any less in this category. If anything, there has been a slight increase. So we can make sure that those who are in need of medical attention would not shy away from the A&E. You mentioned the revision twice a year. This is the case in our system. The HA will be revising or reviewing the fees and charges every 2 years to make sure that they will keep up with the times. That has always been the case. It's just that for some time previously, revision or the review exercise didn't take place. That we're merely following the existing mechanism in this regard. You mentioned why 90% subsidization rate. Indeed, globally in the healthcare system, this is something that they have to contend with. The healthcare services do need to have a co-payment element. In many places, they have the medical insurance, and they also have the co-payment rate. In Singapore, for instance, the co-payment rate can be as much as 20%. In many parts of the world, you take out the insurance, and you also have national insurance. You pay the premium, and when you use the healthcare services, you still have to pay 20%. Or this subsidy will be only 80%. So when we look at this standard, we have had regard to this. And in fact, we are subsidizing at a high rate. 90% subsidization rate is still a pretty high rate. We are proceeding a step at a time, and we have 3 revisions in 5 years, and we seek to achieve this target through this time frame.
呢個
As for the hospital development plan, we will announce the details later. We haven't yet come up with a finalized plan, so we feel that we should wait until time is ripe to disclose the details. Thank you. Next, Ms. Grace Chen. Thank you, Chair. According to the government paper, the government will step up its oral dental health services. I agree. I understand that parents of people with disabilities would like the government to step up oral health service for people with disabilities. I want to know, for this particular group of people, are there measures to benefit them? Thank you. I defer to Dr. Ronald Lam, Director of Health, to address this question. Director, in terms of our oral health and dental care services, we provide extensive service for certain parts of people as well as in-depth services for other groups. Well, our approach is that we have to adopt a prevention approach for the underprivileged as well as those with financial hardship. For example, those with intellectual disability, we provide oral health and dental care services for them. This includes the Community Dental Support Program. Under this program, we offer dental care services for underprivileged groups, as well also for people with intellectual disability. We offer outreach services to residential care homes. We have also allocated resources to our outreach programs. Where necessary, we would refer the cases we come across under the outreach programs to the public hospitals. Thank you. Next, Mr. Mark Chong. Secretary, I have 3 questions. Last year, the Chinese University of Hong Kong Hospital came to apply for further funding, and back then Mr. Michael Tien said that the figures do not add up. Back then, we asked them to come back again after they have redone their calculation. Now, according to the CUHK, recently they said that if they have to repay the debt starting from 2028, it would be very difficult for them. We cannot keep approving loans to them. So have you thought about privatizing Chinese University Hospital like the Queen Mary Hospital if they cannot repay the debt? Also, there have been a number of medical blunders in public hospitals that involve medical devices. Last year, someone from the hospital authority said it would set up a reward and penalty system to ensure patient safety. What kind of medical incidents would be covered under this system? Would that cover medical devices? Now, this morning I went to an elderly care home, and the nurses said that in the past for 16 weeks they charged $15 for the medication, and now the amount goes up to $20. An elderly person got a prescription enough for 6 weeks. Well, will you charge the patient by week instead? Secretary, in relation to the situation of the Chinese University Hospital, I noticed that the chief executive officer made remarks about their budget. I have to stress that we are continuously monitoring the situation of the Chinese University Hospital. We haven't yet got any news about the Chinese University Hospital failing to repay the loans, and there was no news about them asking for further funding approval either. You asked whether the government would consider recovering the Chinese University Hospital. Well, we would consider all options possible. As for the question about medical incidents, I'll defer to Dr. Libby Lee. Now, to respond to your questions about the fees for medication, can we charge patients by week? Well, this could be possible. Some people may get 4 weeks of prescription because the amount they have to pay is the same for prescription for 2 weeks. Well, we will consider your suggestion. Now I will invite Dr. Libby Lee to respond to the other question. Thank you. I thank Mr. Chong for the question. It is right that we have to ensure patient safety in terms of our clinical services as well as our medical equipment and devices. We have to first find out whether the medical incident involved the failure of medical equipment or devices, but we will consider patient safety regardless of what the problem is. Next, Mr. Yu Ming. I want to bring out one point about the A&E services. I understand that the government would like to prevent abuse of the medical waiver mechanism. In the North District, there aren't many private hospitals. Actually, there are none that provide evening services in Tuen Shui Wai. So people may want to make use of public hospitals as much as possible. Well, in order to prevent abuse, would you introduce additional healthcare services in the North District? Also, I understand that 2 hectares of land will be reserved in Santien for building a private hospital. Will the government speed up the development of that private hospital? Will you even consider in Hung Shui Kiu and Hachun introduce a private hospital there? Yesterday, the Development Bureau said land has been reserved for a private hospital. I think it would be better to build a public hospital there instead. For people living in Tuen Mun Yuen Long and Tin Shui Wai, they have to travel far to go to a private hospital. So if there is a new private hospital there, it could help shoulder the burden on the public healthcare system. Also, that area is very close to Shanghai as well as the Shenzhen Bay Port. A lot of Hong Kong people go to work in Shanghai. So if they opt for the private sector service instead of the public sector, will there be relevant services provided to them to accommodate their needs? Well, there is one more member waiting to speak. I suggest that we conclude this meeting after the last member has spoken. Secretary, I will first respond to the question about private hospitals. Now, to build a private hospital in the new territories, it is not just about planning. We have to look at the needs. And more importantly, we have to take into consideration the participation of the private sector. We have to see if they're willing to provide healthcare services in the new territories. Also, if a private hospital is to be built there, will people actually visit that private hospital? So far we don't have any proposals or plans to build a private hospital there. Now turning to the question about the A&E department, well, can we divert patients to private healthcare services offered in the evening? Well, we have to look at the service needs. We have at 25,000 service quotas for evening consultation services. I'll defer to Dr. Pang to tell you more. Now, on primary healthcare development, we look at people's needs in both the public and private sectors. On one hand, we look at the provision of services by private clinics in different districts. Also, as we consider increasing the number of service quotas for evening services, we look at the waiting time of patients at the A&E, and also we look at the provision of service by the private sector. So in the coming year, when we decide on the number of service quotas, we will take into account all the above factors. Thank you. Next, Ms. Christine Fong. Thank you, Chairman. The administration said it would ensure the transparency of price information of private healthcare facilities. I welcome this measure. Will there be an effective mechanism to monitor the level of charge of private healthcare facilities? Also, I agree that we need to strengthen primary healthcare services. Will these services cover eye diseases? For example, will it cover CM services as well? Will there be more DHC expresses? Will there be mobile expresses to provide health assessment services? I know that the Changkwon O DHC is under construction. Will there be a DHC in Ma On Shan? Thank you. Secretary. Private healthcare facilities charge patients based on a free market model. It's not that we are to regulate the price level of the private sector. Instead, they have to make the price information transparent in order to allow patients to make an informed decision. As for the other questions, I will ask Dr. Pang to elaborate. Yes, Commissioner. I thank Ms. Fong for the questions. I hope that members would support our amendments to the Private Healthcare Facilities Ordinance. The monitoring mechanism will be made a regular one. To give you an example, well, there are 3 proposals. First, making public the price information is one of the requirements. This does not only cover private hospitals, but also day procedure centers and clinics. They have to, for example, at their counters, make available the price information. They have to display the information at a prominent location so that patients are aware of the information. Also, before they make any changes to the price information, they will have to report to us first. And the price will have to be fixed. We will make sure that there is going to be enough inspections to make the above measures work. For example, we require private hospitals to provide budget estimates, and the information will have to be provided in a certain format. In terms of publishing historical statistics on fees and charges, again, the private healthcare facilities will have to, based on our requirements, provide the information. The information on fees and charges of the previous financial year will have to be provided. So we will receive reports from them. We will also handle complaints. And there will be a mechanism in place to follow up on complaints. We will perhaps make a verbal advice.
Dr. Peng? Yes, when it comes to the screening of illnesses, we would have regarded evidence to make sure that the screening exercise would achieve the desired effect. And we will be looking to see what screening can be incorporated to improve the health services. The blueprint for China's medicine was published last year. We are exploring how best that we can do our job. And there are services that are available. As to the DHC, we are using a lot of the expresses, and we cover 60 different service points under the DHC network. I'm grateful to members in Ma On Shan and Zhangguanou. The DHC Express will need some time to be up and running, so we have included some service points in the interim. In Shatin and Zhangguo, that there would be such service points. For other areas mentioned, we will have a look at this. Moving on now to any other business. On the 9th of February 2026, we'll be visiting the Chinese Medicine Hospital and also the Chinese Medicine Testing Center. Invitation has been issued to members yesterday. Under Section 29 of the House rule, we need to have half of the members taking part before we can make the trip. And we've also extended the invitation to non-panel members. All right, thank you very much. There are no other AOB items. Meeting is now adjourned. Thank you all very much for being with us.